Hey there, Hit Like a Girl pod listeners. We've got some exciting news that's too good to keep to ourselves. You all know Grace Minton, whose stories have captivated us over the past couple years. Well, Grace has been doing such an amazing job with her show, High Tea with Grace, that it's time for her to shine even brighter. Yes, you heard that right. High Tea with Grace has graduated to its own show with its own brand new RSS feed. While we've loved sharing Grace's episodes as special bonuses on the Hit Like a Girl pod, it's now time to give Grace the spotlight she deserves. So what does that mean for you? To continue enjoying the compelling stories and insights from Grace, head over to your favorite podcast platform and hit that subscribe button for High Tea with Grace. Trust us, you don't want to miss out on what she has in store. Her latest series is dedicated to understanding the VC funding world, aka Fund Like a Girl. Thank you for supporting us, and let's show some love for Grace on her exciting new journey. Remember, search for High Tea with Grace and subscribe today. Hey there, and welcome to the Hit Like a Girl podcast. My name is Joy Rios, and on this show we talk about how complicated the world of healthcare and health IT is. And so each one of our guests brings a piece of the 30,000-piece puzzle because it's that big and that complicated. And I am so thrilled that today I'm in a special location with a very special human, and I will give her a moment to introduce herself.
Yeah, welcome to the Humphreys building.
Woo,
you are at Health and Human Services.
I feel like I've made it.
I don't know if I would call a government like bureaucracy building making it, but yeah, we're sitting in Health and Human Services today as part of your tour.
Yeah, I was looking across the street at the Capitol building and I'm like, okay, so much of the conversations that I have essentially start, I think, in this building or from people within this building.
Somebody down the hallway or down a few flights of stairs. So I'm Andrea Fletcher. I'm the Chief Digital Strategy Officer at the Centers for Medicare and Medicaid Services, known as CMS. I also lead the digital service team at CMS. So we're an agency team of the U.S. Digital Services at the White House. We basically solve really sticky problems in government technology, which is pretty cool.
Okay, so I want to start by asking a little bit about your journey and how you got here, but I also want to address that this is the first position of its kind.
Yes, I am the first person in this role ever.
Yes. So I want to I want you to help explain what the role is, and then I don't know which we should go first, of what the role is and then how you got there, or
I can talk a little bit about the role. So over the past 2 years, since 2021, we've really been establishing an agency digital service team. I think CMS is so large and has so much technology that really kind of having they call us a SWAT team or an unstick it team, a group of people who have technology skill sets, mostly coming in from the private sector. So everybody's on a 4-year tour of service or up to 4 years. So they come in knowing nothing about government, sometimes nothing about healthcare. They all have a technology background, at least. They get up to speed on things on our team, and they help different parts of CMS who are struggling, whether they're writing policy and they're trying to understand how that policy affects healthcare payers and providers and the technology they use. So we will send user researchers out to talk to electronic health record companies and get demos of how people are pulling software, or talk to hospitals, talk to providers. And then we also do public facing stuff. So we do a lot of work around cleaning up a website or cleaning up a form or a process. Right now, we've been looking a lot at how people complain about something in the healthcare system.
Oh, I'm sure that's a lot of fun.
Yeah, and it's not fun whenever you get sent to a government website that looks like a government website and you're told to download a PDF that is only available in English and is not accessible for people who have visual or cognitive disabilities. And, it's a challenge for the American people who are just trying to get something or prevent something bad from happening for someone else in the future. And so a lot of the work that we end up doing is just supporting other components or other offices who are thinking through something, and they might not have the technology skill sets to really dive into it, or the time. Often people don't have the time. They're busy with 15 other things. And they're like, hey, we could just use a little extra help. And so that's where our team comes in.
So I was in a conversation, or I was witnessing a conversation at a conference yesterday, and they were talking about how the government has typically had a team of people who create the policy and then a whole separate team of people who implement the policy.
Yep. It's very divided.
And are you the connector or the bridge between that? Okay.
Sometimes we are. A lot of times we're more on the implementation side. If we're lucky, we get brought in on the policy side early before somebody writes something into a rule. The rule-making process is very complicated. But before somebody writes something into a rule that is actually really tricky to implement, particularly around collecting data. That's one where we get brought in quite often of how do we collect this information in a way that doesn't add burden onto particularly providers and payers in our case. And can we help design a better way of doing that? So sometimes policy, mostly implementation.
Now I have other questions. So it's mostly provider and payers. What about patients? Are you involved at all in patient education?
Oh, yeah.
Okay.
We have millions of beneficiaries. CMS touches about half of the U.S. population indirectly benefiting from health insurance programs or social service programs. So Medicaid, for example, is somewhere around 88 million. Medicare, I think we're roughly at 64 million right now. That's increasing daily. And then also the marketplace or healthcare.gov, Affordable Care Act, Obamacare, choose your phrase for it. And two of those have two of the largest websites in the federal government. So we own Medicare.gov, which gets millions of visitors a day, and healthcare.gov, which also gets millions of visitors a day.
Are you involved at all in healthit.gov or no?
That's the Office of the National IT Coordinator.
Okay.
Yeah. That's a part of HHS. So we're also a part of HHS. We also have a huge building up in Woodlawn, Baltimore. So most of our staff are actually north of us.
I need to talk to all of you.
Yeah, you should. Government's cool.
Yeah, it is. I mean, you guys get involved in so much, and it also is varied state by state. So how you keep track of all of that is incredible.
Yeah, and we all have to coordinate with each other, and sometimes we don't very well. and we have to try to make rules and be fair, and then enforce those rules, and also provide health insurance and process, like Medicare is a huge claims processor. So we're a payer in all of this as well.
Yeah, no small feat. It is no small feat.
There's a lot going on.
Tell me about some of the projects that you're currently working on and that you're excited about.
Some of the stuff that we're currently working on, we have been working on for 5 years, modernizing the Medicare payment systems.
Big deal.
Yeah, I think the last time I looked, it's about $750 million a year are spent on those systems.
Wow.
So these are huge systems. They cost a lot of money. It also provides roughly 20% of payments in the healthcare sector. I don't know. I don't actually know the number on that. So
it's
maybe scratch that too, Marco. It's a lot. It's a lot. It's a lot of money. It's billions of dollars. The number that I've always kind of referenced is 4.5% of the US GDP passes through Medicare payment systems every year. So it's a big one.
So it's the back-end systems that you're working on updating.
Yeah, the law was enacted in 1963, and that's when we got A and B. And over the decades since, we have added other parts to Medicare. Part C, most people are familiar with. Medicare Advantage. Part D, which provides people prescription drugs. And each of those has their own processes that have to occur. And all of this has been built by federal government contractors over decades. We have mainframes, we have COBOL, we have all kinds of legacy systems and patches to the systems and the policy that goes into all of this. We have the Medicare administrative contractors, which are billion-dollar contractors who process claims for providers. So it is a behemoth of a system.
So what does success look like for you in terms of updating all of that?
That is a great question. I wish I had an awesome answer. All of it not crashing down on our heads while we're trying to do it. We talk about a lot. The way that we often talk about it is that it's not necessarily the technology, because COBOL and mainframes are efficient and were great technology when they were implemented. It's the business processes. So making sure that we are reworking and reconfiguring our business processes as we're building, new tools in the cloud, or, translating COBOL to Java is not a good solution if the COBOL was poorly written and you translate it into poorly written Java.
Right.
You have not solved your root problems. And these systems are incredibly complex. Like, I have never met anyone who has them all in their head at once. Even a map of them. I need to put one on our wall. We need some good office art of a map of all of the systems. They're like mind-bogglingly complex, right? And the policy builds on top of the systems and,
Okay, so what kind of background do you have in order to manage all of that?
That's a great question because I'm not a computer scientist.
Okay.
I don't have a traditional IT education. My background is in public health. So I did an undergraduate degree in biology and philosophy, and I loved bioethics when I was younger. I still love bioethics.
Sounds fascinating.
Yeah, like, should we be doing this thing that we're going to do? Is it just? Is it equitable? All of those kind of cool concepts. And then I did a master's in public health. So I have a master's in public health in global health, which is very different than most people in this building, honestly. Mm-hmm. And then most people here are policymakers. They have policy backgrounds. And then I accidentally went to work for a startup. Didn't realize that it was a bunch of engineers, but it ended up being a really great choice because I learned how to build software, building software.
Yep.
So I worked for a company called Damagi. Out of the MIT Media Lab in Boston. They sent me all over Africa. I spent almost a decade there, and then at another firm called Cooper Smith, providing technical assistance to other governments. So really working internationally on how other countries build out their health IT systems.
Okay, what do you learn in that? I mean, you've learned so much.
There's so much. Yeah. There's so much. It's really interesting to me because, especially low resource countries or low income countries in sub-Saharan Africa, they've gone open source very, very quickly, almost immediately, built everything on...
Because they're able to hopscotch.
They're able to hopscotch. They're not dealing with COBOL and PDFs.
They don't have to update old legacy systems. They can just start with new systems.
Yeah, in some cases, the legacy system is, a server under someone's desk, and a new system is cheaper to build anyway. And they're able to build them user-friendly. They're building them in national healthcare systems. So rolling out to every clinic in the country or every district in the country is quite easy for them. Whereas for us, it's very different. Mm-hmm. I'm learning a lot about how states and the federal government, like how federalism works. It's not as easy to push things out to everyone. It's not as easy to get something into every hospital or clinic in the country. Whereas in a national healthcare system, it's very different.
Right. I live in Mexico. So it is slightly different there too, and very close to the border, but I get to see both sides of the border and how I'm still learning a lot, but I'd be interested to compare notes on African, what they do in Africa.
There's so much that we can learn from what other countries do in this space. And there's so much that they learn from us as well. But that's one of the things that's been really fascinating to me throughout my career is like how similar all of this is. Like, we're all trying to solve the same problem, the same use case. We're trying to deliver people healthcare services. Like, at the end of the day, that's what everyone's trying to do. And how we solve that problem, we go about it in different ways.
Absolutely. I think about health equity, and you're like, okay, what does that... It's not just what does that mean in theory, but in practice, and how do we make that happen? And especially in the light of so much new technology coming, I like to think of it's amazing how technology has enabled us to do so much. And yet there are still so many people that don't have access to it. And how do we make sure that they get the care that they need? Yeah.
I think about this a lot with telemedicine, which telemedicine, if you have mobility issues, can be incredible. Like, that is a huge advantage now to getting better access to healthcare. If you can't, it's difficult for you to leave your home. But if you live in a rural area, telemedicine might not be great because of connectivity issues.
Right.
I've been thinking a lot about telemedicine lately, mostly also because I get asked questions about it.
Well, it's important. I've been in conversations around the maternal health crisis and thinking about maternal health deserts and where people don't have access to care and how do we support them? And that's not an easy answer. There's a lot of people that talk about what they are doing, and then we're like, okay, but similarly to conversations around who's at the table and contributing their opinion, but who's not at the table and what conversations are missing. And that's hard to keep it in the forefront of your mind in general. So I imagine that's a difficult thing to do in your position.
Well, and technology isn't always the answer or the only answer. In fact, sometimes it can make things worse. I spent a lot of time building apps for frontline healthcare workers, particularly in sub-Saharan Africa. And that was a really interesting thing to work on because it taught me, one, the value of talking to users. Just, put it in front of people's faces early and often. And that an app on a broken process is now a broken app.
There you go.
So all you've done is put an app on top of something and it's still broken. And so you have to go back to the service design and the service delivery and understanding, your processes. And in government, this gets really interesting on the implementation side because the processes were not always designed. They were designed by, years of policy being thrown on top of each other.
Right, of course. And a lot of times the policymakers aren't really understanding how that affects the people that have to implement it.
No, because how we talk to people is through comments on, the Federal Register and requests for information. And
that's not a really a normal way to talk to people or
not
gather
if you're building
feedback.
Technology. No technologist would ever build a piece of technology that way.
Right.
They would write a user story and they would talk to users. So it's this total, almost like heads butting against each other in the way of how a technologist does things versus how a policymaker does things. And it's interesting to that's why when you ask, are you policy side or implementation, I'm like, sometimes both, sometimes in conflict with each other.
Sure. But if you're coming in as sort of a new way of doing things or possibly bringing change, how receptive are people to that?
Some are not. I will be honest. It's the bureaucracy.
Yeah.
Bureaucracies like to do things the way that they've always been done.
Yep.
Because, and people will say to me, I don't want to go to jail, right? Me neither.
Me neither. Who does? Who does?
Yeah. But, the way that it has always been done and bureaucracies are kind of built in a way to protect yourself, right? Protect yourself from being called in front of Congress to talk to people, protect yourself from litigation, we get sued by all kinds of people all the time, right? And that's, if you do it the way that it has been done and the way that and you follow the rules, you will protect yourself, you will protect the agency, right? That is not a great way to transform the healthcare system and to do digital transformation.
Well, that's the thing. Your title is part of the digital transformation.
Yeah, it's a big phrase. Let's not digital strategy and digital transformation and modernization. There's some hopeful thinking in that.
Yeah. So how long have you been at this?
2 months.
Okay.
A year on the digital service team and about 2 months in this role now.
And are you only allowed to have the 4 years or are you allowed to have more?
So I'm career service now.
Okay.
I have flipped over. But most of my team is still on a tour of service. Some of them will stay at CMS. Some of them will stay at HHS. Some of them will decide to go back to the private sector. And I love the tour of service model. I think everyone in the country should serve at some point in whatever capacity they can. And there's an amazing component here of people taking time out of their job at a big tech company to come help solve healthcare.
But it kind of sounds like the Peace Corps, but some sort of...
Yeah, but for high level techies.
How does somebody get involved in that? Because I've never even heard of it.
You can apply online. Yeah, we recruit, we take applications. The federal government, I think, in general is going through a bit of a movement or a revolution around hiring in technologists and what does it look like to have technologists at the table when policy is being made and when implementation and operations are having conversations, because so much of what we do involves technology in some way, shape, or form. So we've got, everything from coding it forward interns on our team who are in school, have technology backgrounds. We've got product managers, designers, engineers coming from coding it forward. We then have digital core fellows who are within 2 years out of their degree program. So undergrad or master's or PhDs. We've had PhDs come through that program as well. And they are, or doctoral degrees, they are on a pathways program. So they come in and they rise up quickly, basically, is how a pathways program works in the government. But early career technologists is what we call them.
And you don't necessarily have to have a computer science background.
No, you can have a design background. We need designers of all shapes and colors.
Heck yeah, we do.
Yeah, we need people who can write good content. We need people who can do user experience and user research design, because nobody likes a terrible government form.
Yeah, that's so true.
And HHS, it's not just HHS, it's CDC and NIH and FDA and all these other parts of HHS that also need people.
Wow. Okay. So can we just take a minute to share how people would find that information? Because I really am interested in, like, how do we lead people to come be part of the solution?
Yeah, come solve problems.
Yeah, because there's a lot of problems.
We got some big problems over here. Yeah, so you can go to those programs. You can come to our website, digital, I think we're cms.gov/digital services.
Okay.
The U.S. Digital Service also takes applications. There's several different nonprofits in the space as well. So the Tech to Gov partnership. If you don't want to leave your current job, you can volunteer with the U.S. Digital Response, or Code for America is another group that works with mostly at state and local levels. There's a whole civic tech community out here.
You're blowing my mind. I didn't.
Really?
Yeah, I honestly didn't know all of this. And I feel like I talk to a lot of people. I mean,
and no one's talked to you about like the civic tech community and how awesome we are and how we're like trying to fix problems.
No, I mean, it's just sort of like this big conglomerate of the government, and you get access to them at different conferences or whatnot, but no one's broken it down in this level of detail.
Oh, I'm happy to do that.
Yeah. There's actually a track of like,
yeah, depending on where you're at in your career and what you're interested in. I mean, you probably got to do a little bit of research.
Of course.
There's some people, pulling information together on, how you apply to these different programs. And my advice is always to apply to many things.
Sure.
Because you might not get your top choice, but you might get your second choice. And
you're still going to be doing a lot of good.
Yeah. And, I came in through the U.S. Digital Service, which it's high level technologist. I honestly, if I'm being honest, I did not think I would get in. I remember applying and being like, I'll throw out an application here. And I threw out applications to other parts of the government as well. And it happened to be during COVID-19, and they were looking for people who had backgrounds in technology and public health, which I do.
Yeah.
But I'm not a computer scientist. I'm a product manager, or, I manage stakeholders a lot of the time is what I feel like.
But a lot of times it's probably important to be able to see the big picture, and you don't need to know the details of every single thing, but you want to be able to, I'm sure, direct a group to go in the right direction.
Yeah, direct a group to go in the right direction. I feel like I often am like a translator of languages, right? There's government speak. We have a lot of acronyms.
Tons.
So many acronyms. And learning, which laws and which rules you have to follow. Like, this is a hard and fast rule, and where you have wiggle room in those laws and rules, and how you can navigate through the bureaucracy. How do you get people to yes in the government?
Right.
What do they need to feel comfortable? And then, so there's government speak, there's technology speak.
Tons of acronyms there too.
Tons of acronyms, tons of weird things. We were talking about artificial intelligence the other days, and llamas, and, just the nonsense. Or I think I said the phrase, we have to put the Python on GitHub, right? And then I thought for a second how absurd that statement says. If you are not a technologist and you don't know what Python and GitHub are.
Right.
Like, what?
Like, I'm lost. What language are you speaking?
Yeah. And so you have to step back, 10 steps and explain to someone what GitHub is and why it's important and why we're using, and so it's a different language than government. And then the third language is healthcare, which is also filled with acronyms and Latin and weird language,
Yeah. So you're working on the federal level. Are there any initiatives or projects or within particular states or regions that you're really excited about? And
I mean, I get excited about Medicaid in general.
Oh my gosh, tell me.
I don't think a lot of people get excited about Medicaid, but I do. I think there's huge potential in the Medicaid system.
Okay, but I always think that there's huge potential, and then I get sad that people aren't using it to its potential.
That's a fair criticism. I think there's a potential, and this comes from my experience abroad and how we built systems across multiple countries and multiple, districts or states within a country at a subnational level, and really thinking about the architecture of that and how you build once and use many, because I don't think we're doing that right now necessarily in Medicaid and state systems in particular. and how we adopt a reuse recycle model that benefits states and benefits that maybe decreases the cost of systems because we have incredibly expensive systems, and improves the usability and improves the data quality, and really just start to reimagine. I think the public health emergency is a great opportunity to look at the state systems and look at how we interact between states and the federal government and reimagine a world that's different, because I've seen this different world and it's pretty cool. Like, it's pretty exciting.
But are there, I don't want to call any state out for being special or not special, but like, are there any that you think that would be a great model?
Yeah. I mean, since you haven't been in that civic tech space, there's state digital service teams too. So we have the Colorado Digital Service, we have Code PA who just stood up, and they're kind of our counterparts in taking a look and digging into some of these systems. There's cities that have been doing great work. The city of Baltimore, the city of Philadelphia have digital service teams. Colorado's always been a little ahead of the game. California's always been a little bit ahead of the game. New Jersey has an Office of Innovation that's pretty forward leaning. There are some teams out there that are really rethinking, especially coming out of the public health emergency and COVID-19. How do we do this differently?
Now, for the folks that are on the other side of that coin, how do we pull them up faster?
The ones that aren't?
Yeah.
I will always talk about hiring, always, because the talent is the hardest part, convincing people that they might have to take a little pay cut in order to come into government service.
Okay.
Or we don't pay as much, I'll be honest, as the private sector, but the impact is so large that you can change millions of people's lives with the code that you write. That's pretty cool.
That's really cool.
Yeah. And so getting talent into states to help them make decisions on the software that they're buying and building. In government, we buy a lot of software, but you want to have people who understand what they're buying, as a good purchaser. And that's not always the case in the federal government. And it's not always the case at the state level either. We call it procurement. So how we procure software. And in a waterfall world, what typically happens is they write the requirements for the software, and then it goes through the procurement process. And by the time it actually gets procured, it's 2 years later, right? We purchase the software 2 years later. And then by the time it gets implemented, it's 3 years later. So we are trying to buy software for 5 years in the future. That's why it doesn't always work out in our favor.
That's got to be one of the hardest things to manage, especially at the pace of change of technology these days.
Yes, exactly. So if we wanted to buy AI stuff, we should have bought it 5 years ago.
Yeah, exactly.
Yeah. Yes, exactly. And have the budget pulled together years ago. And so...
Well, you should just be a fortune teller then.
Basically, yeah. Or you have to restructure the way that you buy software. You have to rethink how you do that, how that process works. You have to do it in a more agile and iterative way, which is not how government does things.
And also question about startups, because that's such an investment in the future that if for companies that are new and just getting started, you kind of have to guarantee that they're still going to be around 5 years from now to implement.
Yeah, and it takes a team of people to respond to a government contract, which is why somebody will say, well, why didn't you hire this brand new, innovative, awesome company? And we're like, because they don't have somebody who can respond to our request for proposals.
Which is a huge, it's a huge burden. Time consuming. Yeah, it's a big lift.
It's lucrative if you can do it, but that's why you end up with companies and organizations who can do government contracting.
Yeah.
And so, there's a whole group of people out there who are working on how do we do government contracting differently? How do we bring new companies and organizations into the government contracting arena so that way we have firms who can do agile development and user research, and because when we're doing user research for Medicare.gov, it's massive user research.
Of course.
It takes a whole firm.
We want your whole team 8 hours a day or more for a year.
Basically, yeah. I mean, it's a multi-million-dollar effort to make sure that a website like Medicare.gov or Healthcare.gov is user-friendly and accessible and makes sense to a human.
I've paid a lot of attention to Physician Compare or Compare.gov, and that's changed significantly even over the last few years. And it's been interesting to see how it gets consolidated and, trying to be more user-friendly so lay people can understand quality measures and, how all of that gets displayed.
Yeah.
It's fascinating.
There's a whole team of people behind that.
Of course. course there is.
Multiple teams.
So for people who might be interested in getting jobs within government, okay, fine, you might have to take a pay cut, but it also sounds like you'd be pretty well set up for a future after if you wanted to move from government to back to the private sector.
Yeah, I think you learn a lot being on the government side about how policy implementation works, like really niche parts of healthcare technology.
Yeah.
Fire, FHIR.
Yeah.
Like we deal with it a lot. And X12. So like standards, how payment systems work. Like if you're working on the Medicare payment systems, how claims processing works. Like that is a very niche understanding.
I've been having a conversation about the US CDI standards and how that new update has been coming along. And it's specifically on the SOGI, so sexual orientation and gender identity data. And it's just connected to health equity in the sense of how can we provide access to folks or serve different communities if we're not collecting data about them in certain ways. Does that come across your table or desk?
It does sometimes. I mean, we collect so much data
I bet.
at CMS. I would argue that we have some of the largest healthcare data sets in the world.
Right.
I mean, we have all of the Medicare data, claims data. We have an entire office of minority health who looks at SOGI data and other data collection for health equity. This is not my expertise, but we do have a lot of data and we collect a lot of data and then we publish a lot of data as well. We are a processor of data. That is a huge thing that we do as an agency. And so, how we as the government collect information is incredibly important, and what standards we use, how we collect data from the states and providers.
And also making sure that technology is capable of collecting the same data.
Bingo. Because not everybody uses the same EHR.
No, that's right.
Some don't have EHRs, right? And so we're dealing with different types of data collection from different people, from different entities. Yeah.
It's massive. Everything, all of it. Like, it's no small feat what you are doing.
Thanks. Yeah. I am probably about once a week, my mind is blown on something that the U.S. government does that I didn't think about.
Tell me about the last time. Can you remember the last?
It was interesting. I was reading an article about Maui, actually, about what the disaster there, and HHS deals a lot with disaster response. And I thought, FEMA's handling a lot of that. But no, did you know that we have mobile mortuary units that HHS deploys that have forensic scientists and morticians, because when different areas become overwhelmed with a disaster, they need support not just on the healthcare side, but also on dealing with mass casualties. And I thought about that for a second of like how incredible it is that is a thing that that exists, because those communities need that. I mean, it's a terrible thing to need support for, but they need additional support, and that we have this team and apparatus that deploys. And I was like, that's Health and Human Services, not,
Wow. Yeah. So what else have you learned from your own department? Because that's pretty incredible too.
CMS does so much. Yeah. The Center for Clinical Standards and Quality is one that I don't think many people know about. So they're responsible for healthcare quality. They're responsible when something bad happens in the healthcare sector. So if somebody shows up in an emergency room and they're denied care, they can make a complaint and that gets processed through CMS. If somebody, has a nursing home, they're in a nursing home and their care is not proper, that's a CMS. CMS gets that, right?
Yeah. Yeah.
And I think about the relief that we give people, that somebody is there to hear, to listen to them and to try to make sure that this doesn't happen to someone else, and try to prevent these things from happening to people. Because as much as we all want healthcare to be perfect every time we go into a facility, it's not. The reality of the situation is some people do have terrible experiences in the healthcare sector. And I always enjoy talking to them just about how complex and complicated that work is, because you also have businesses, right? You have hospitals, you have providers of all different sorts. You have laboratories, you have payers, insurance companies, and we need all of these things for our healthcare system to run. But we also need to trust that they are providing care that is appropriate and, the highest quality care that's available. And somebody has to, make sure that's happening. And so that's where CMS comes in.
So perhaps my last question, but maybe not. We'll see. Is thinking about, and I track quality measures big time. I'm like, thinking about gaps in care, what it is that we're measuring so that because we say that it matters. Does CMS or HHS ever actually be the originators and generators of those quality measures, or are you waiting for the public or an organization to introduce those to you?
To understand this.
It's a big question, kind of.
Yeah, I don't know enough about it. See, this is the other problem. It's like, that's such a deep expertise area that I'm like, I got to call up somebody who's an subject matter expert in that. We do investigations. So if somebody submits a complaint, CMS will do investigations. And that's kind of what I was thinking about earlier, is like our investigation processes and how we go about responding to, it was in the Theranos documentary
Theranos.
The Theranos movie or miniseries. It was CMS. They made a complaint to CMS, and CMS investigated the laboratory for quality standards.
So the reason I'm asking the question is because kind of chiming back to the maternal health crisis, that I'm like, okay, tracking quality measures, those are typically based on Medicare population, but maternal health isn't really in the Medicare. Yeah, it's all Medicaid. And so that's the part. I'm like, okay, well, we have to solve for that, but it is so freaking hard because it's not driven by Medicare, which is the biggest driver of healthcare quality, healthcare delivery. But it's a very specific population, right? And then you're like, okay, well, then we're missing a whole lot. So how do we close those gaps? And I don't expect you to have the answer to that.
I wish I had the answer. I wish I had the answer to everything on this. Yeah, I mean, to go back a little bit on like things that I am just like surprised by that we do. I mean, just the fact that somebody is looking at this data and the fact that somebody is collecting this data doesn't always happen everywhere in the world either. That is a huge benefit of like the work that is done in our government, is that we are collecting and we are looking at, there are gaps in this data. Just knowing that is key to addressing it. And that doesn't always happen everywhere in the world because they don't have the systems and technology in place.
Well, I think a lot of times it's easy to think about what's right in front of you or whoever's perspective is here at the table. But one of the hardest things to grapple with is who's not here. And how do you measure a negative? There's a fun analogy about like, if say Superman saved the world from whatever, like a meteor, right? You're just like, well, how would you measure the damage that wasn't done? Even
cost avoidance is what we call it in government. We did not spend money. It's a real thing. Nobody cares about the money that you didn't spend.
Right. And you're like, that's a huge, it's a massive benefit to be able to say, well, look how much I saved you. But it's hard if you didn't have to spend that money or recover from a huge emergency.
Spend this money. We didn't do this thing.
Hard to track that.
We saved somebody from a terrible technical decision.
Exactly.
Yeah.
Well, I imagine you might be you're probably not hard to find, but maybe.
No, I'm on LinkedIn. I have an email address. There's like a bio about me online somewhere.
I found it. Are you allowed to be on social media and connect in that way or no?
Yeah, I could be. I don't really. Like, I'm pretty much just on LinkedIn. Yeah, I'm also not good at it.
Yeah.
I've basically succumbed to the fact I'm never going to be an influencer.
That's fair. Well, I would love to bring more attention to the work that you do, and I'm happy to have had this conversation with you. Thank you.
Let's get more people from the government and civic tech. Out there in the world talking about what we do.
We need to know more about what you guys are doing and really just like say thank you because you're doing the hard work.
I really love it. I feel like I have found like where I belong in life in terms of, it's funny because I spent so much of my career abroad, and moving to the domestic side of things has been I've learned so much.
I bet.
And it has been a really interesting experience of like looking how seeing how the U.S. government functions and comparing that to previous experiences and how our healthcare system functions and how we collect information and data and build systems. And there's so much good work to be done. And there are so many incredible people in the federal government who are just doing their jobs every day. And by doing that, like millions of people get
benefit.
healthcare.
Yeah. Benefit. Yes.
Yeah.
I always think like there's no shortage of work to be done. And anytime you think like you might be like, nope, we've got a lot to do. And
yeah, we're a roll up your sleeves and just get work done kind of team, which is kind of fun to be on because, you know, we're often just like, all right, somebody's got to go write that code or build that form.
I am wishing you all of the luck in the world in the digital transformation.
I'm going to need it.
Yeah. We are glad that you are leading the charge and hope to send more people your way to support the good work that you're doing.
Come on in, apply.
Yeah.
If you're thinking, you're waiting for the call to action, this is it. This is your call to service.
I love it. Well, thank you for spending this time with me.
This was lovely.
Yeah. Right.
You're good?
I'm good. Thanks for listening. You can learn more about us or this guest by going to our website or visiting us on any of the socials with the handle Hit Like a Girl Pod. Thanks again. See you soon. Again, thank you so much for listening to the Hit Like a Girl podcast. I am truly grateful for you, and I'm wondering if you could do me a quick favor. Would you be willing to follow or subscribe to this podcast, or maybe leave us a rating or review? Or if you're feeling extra generous, would you share this episode on your Instagram stories or with a friend? All those things help us podcasters out so much. I'm the show's host, Joy Rios, and I'll see you next time.